Welcome to the YouTube live book reading of Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. And I'm your moderator and narrator, Uriel Neville Riley. Welcome, YouTube. All right. Peace. It's the 23rd day of October. Now, we had the grocery giveaway yesterday here in South LA Cafe, and it was wonderful. So, sending love to everyone from Slack team. Highest heart love. Did it again. Love to all the book readers and the book lovers community. What's going on, y'all? All right, so we pick up here in the 25th chapter. And this is really getting good. Top of page 384. Here we go. Control mode CPPV, IPPV plus PEEP. Capabilities, same as for control mode IPPV and PEEP. Direct V over Q effects, same as for control mode IPPV and PEEP. Clinical indications, same as for control mode IPPV and PEEP. Monitors, same as for control mode IPPV and PEEP. Suggested application. 1. Stabilize IPPV as best as possible, then titrate PEEP. 2. Always reevaluate necessity for control mode once adequate PEEP level is reached. Control mode is frequently unnecessary unless there is CNS or severe cardiac malfunction. Frequently, a higher level of PEEP is required once the augmented mode is established. Augmented mode CPPV, IMV over IDV plus PEEP. This is the most physiologically advantageous mode of PEEP therapy in critically ill adults. Capabilities, same as for augmented mode IPPV and PEEP. Direct V over Q effects, same as for augmented mode IPPV and PEEP. Clinical indications, same as for augmented mode IPPV and PEEP. Monitors, same as for augmented mode IPPV and PEEP. Suggested application. Priorities for decreasing therapy. One, decrease FiO2 to 0.4. Then 2, decrease ventilator rate to the lowest reasonable level, even if some increase in PEEP level is necessitated. And then 3, decrease PEEP levels. Peace, highest heart love. Thank you so much. Much love, Yusef. Thank you for reading with us. Here we go. We are in the 25th chapter. CPAP. One of our favorite tools, right? For helping others breathe and for respiratory care. This is PEEP therapy applied to the patient who is capable of assuming all the work of breathing. EPAP. Capabilities, same as for PEEP. Direct V over Q effects, same as for PEEP. Compared to CPAP, EPAP may improve cardiovascular function in patients in whom an increased work of breathing is not detrimental. Clinical indications. 1. Same as for PEEP, but only when the patient's ventilatory reserve is excellent. And 2. When intermittent PEEP therapy is desired in non-intubated patients. Monitors. Same as for PEEP. Suggested applications. 1. In patients with excellent ventilatory reserve but limited cardiovascular reserve. And 2. Since the equipment is less expensive and simpler than CPAP equipment, EPAP appears to call a cost-effective technique if the patient can tolerate the increased work of breathing. Top of page 385. Non-cardiovascular complications of airway pressure therapy. The critically ill patient succumbs to either 1. The primary disease process becoming overwhelming. 2. The primary process causing malfunction of originally uninvolved organ systems. Or 3. Iatrogenic, doctor calls, physiologic stress from diagnostic, therapeutic, and supportive interventions. These 3 factors are often difficult or impossible to delineate clinically. For example, a 50-year-old previously healthy man contracts a severe bilateral gram-negative pneumonia and experiences septic shock. 36 hours after septic shock, the kidneys stop functioning. Is the renal failure a result of 1. The initial septic insult, 2. The sustained hypotension that followed, 3. A renal toxic effect of the antibiotics administered, or, as most often occurs, 4. A combination of all these factors. Peace. You too. Thank you so much. Yes. Medical science books. Yep. This is the peaceful part of YouTube where we read books and learn from masters. And I'm Master Uriel Neville Riley, Master Fitness Trainer. And we read books in this part of YouTube. So thank you so much for being here. Let me make sure. All love. Thank you so much. We're in the 25th chapter, in the middle of page 385. In order for the respiratory care practitioner, nurse, and physician to intelligently evaluate such matters, it is essential to understand the potential insult of airway pressure therapy on various organ systems. Following is a discussion of the potential non-cardiovascular complications of airway pressure support. The cardiovascular effects, e.g., decreased cardiac output, hypotension. Vascular volume space relationships are discussed in detail in chapter or section 7. Mechanical malfunction. This is probably the most common preventable and reversible complication of airway pressure therapy. The myriad of interconnected tubes, valves, gas sources, alarms, and monitors and gauges create the milieu for malfunction. The probability of less than optimal functioning of some component of the system is significant, even when the equipment is excellently maintained and monitored. The possibility of catastrophe is ever present. A well-organized, well-trained, and dedicated respiratory therapy department is essential to safe and optimal respiratory intensive care. The question is not how little can one get away with, but rather how much is needed to provide optimal therapy at the least patient risk and cost. That's the key, right? Let's drop a pin there. Ding! That is the key. The question is not how little can one get away with, but rather how much is needed to provide optimal therapy at the least patient risk and cost. That's what we want. That's what real love is, right? Real care is. We want the best for everyone around us. That's why I come here, this peaceful part of YouTube, and read these books. I want the best for us, for all of us, so we can grow. Humanity, we must unite. We should be building mirrors, pyramids, aligned with the stars again. We can do it. And I've already started devising a way. A basic rule must never be violated. Treat patients, not the machine. Any questionable machine or circuitry malfunction must be addressed after the patient is assured adequate ventilation and oxygenation. A properly functioning self-inflating hand ventilator that can be easily connected to an oxygen source must be at each bedside. An appropriate PEEP attachment should be readily available when the patient is receiving greater than 10 centimeters H2O PEEP. Whenever equipment malfunction is suspected, the patient should be disconnected from the apparatus and hand ventilated. Patient evaluation to assure adequacy must be immediately undertaken. Only after the patient's safety is assured should the equipment be examined. Airway malfunction, obstruction, cuff malfunction, displacement, extubation, or bronchial intubation, and disconnection are probably the second most common preventable and reversible complications of airway pressure therapy. These have been discussed in Chapter 16. Appropriate alarms and the appropriate personnel response to these signals are paramount in preventing catastrophe. Pulmonary barotrauma. Barotrauma generally refers to lung rupture secondary to airway pressure phenomena. In relation to airway pressure therapy, barotrauma refers to an alveolar gas leak to extraparenchymal structures. Pulmonary barotrauma includes interstitial emphysema and pneumomediastinum, subcutaneous emphysema, pneumoperitoneum, and pneumothorax. Yes. Woo! Those are so tough. Yes, we did it. Interstitial emphysema. A chest x-ray diagnosis, it is usually the result of a surface bleb or alveolus that ruptures but does not disturb the visceral pleura. Gas dissects along blood vessels, connective tissue sheaths toward the hilus. The clinical significance of interstitial emphysema is that the gas must decompress and therefore possess a constant threat of dissection that will tear the pleura and result in pneumothorax. Pneumomediastinum, a chest x-ray diagnosis. Seldom will tension become a problem since decompression readily occurs via dissection, either 2, 1, the cervical fascial planes, 2, the retroparietal space via the esophageal or diaphragmatic hiatus, or 3, pleural rupture at the hilus. Although pneumopericardium is rare, it is potentially life-threatening and must be immediately evaluated for decompression. Very key. All right. Live from the light here in LA. Thank you so much for being here with us and reading books, all the book lovers community. Thank you for the likes and subs. We're pushing towards 600. Yes, reading books on this part of YouTube. So thank you so much for being here. Yes. Oh, thank you. This is clinical application of respiratory care. We are in the 25th chapter, way up there in the book, 386 page at the bottom. All right. Yeah, so yes. Thank you so much. Oh, hi, it's hard enough. Yes, yes. To help the people, we read to the people, right? It's love. It's all love. This is the peaceful part of YouTube where we read books and learn from masters. So, hi, it's Heart Love. Thank you so much for reading with us. Subcutaneous emphysema. Most commonly the result of mediastinal gas decompressing via the contiguous cervical fascial planes. Neck crepitus, palpitation of subcutaneous air, is often the first observed clinical indication of barotrauma in patients on airway pressure therapy. Although not harmful in and of itself, full-blown subcutaneous emphysema makes the patient appear grotesque. Pneumothorax must constantly be ruled out. Subcutaneous emphysema of mild degree may result from tracheostomy or chest tube wounds. All right, at top of page 387. Pneumoperitoneum. Most commonly encountered following closed chest cardiac massage. However, it does occur in other circumstances. This usually represents mediastinal decompression via the retroperitoneal space. Pneumothorax, the most dangerous type of barotrauma that commonly occurs in patients receiving airway pressure therapy. The pleural air compresses lung and creates hypoxemia. When pneumothorax is present in conjunction with airway pressure therapy, a chest tube must be placed. This will almost always relieve the lung compression and will usually avoid tension in pneumothorax. Okay, and I will put the vocabulary in the description when it's finished uploading. So, man, hi, it's Heart Love. Thank you for reading the medical books with us live from the light here in LA. So, this is part of, giving back to the people. And that's what we want to do. Uplift the people. Keep them steady. And when we're rooted in wisdom and knowledge, right, we can reach further. We can see further. We can plan. And at peace, we can plan and create at its best. Tension pneumothorax. Tension pneumothorax is air in the pleural space under greater than atmospheric pressure. When untreated, in conjunction with airway pressure therapy, it will collapse lung, compress the mediastinum, and compress the great veins and atria contained therein. Tension, pneumothorax in conjunction with IPPV or PEEP may rapidly result in total inability to ventilate and total circulatory collapse. Without immediate thoracic cavity decompression, death will ensue. Decompression. A needle inserted into the chest in adults will usually confirm the diagnosis, but most often will not adequately decompress the gas under tension for any significant period of time. The chest must be opened. A small skin incision is made over the second and third rib between the midclavicular uh, and anterior axillary line. This is followed by placement of a closed hemostat through the incision and insertion into the chest cavity immediately above the rib. Intercostal vessels run below the rib. That's right, to the subcostal. Once the hemostat is inserted and open, adequate decompression will occur and the immediate emergency is over. Positive pressure ventilation does not require a closed chest. Therefore, the insertion of the chest tube is not immediately necessary and should be accomplished under more sterile conditions by skilled personnel. Yes, we'll put the vocabulary in the description when it's all complete, finish uploading. Thank you again for reading books with us. The likes and subs, highest heart love. PEEP therapy and barotrauma. Bottom of page 387. In a review of over 600 consecutive patients receiving airway pressure therapy in our institution, 7% had pulmonary barotrauma. A majority of patients with barotrauma had either pre-existing chronic obstructive pulmonary disease, or COPD, or had expressed pulmonary trauma, including surgery, closed chest massage, and subclavian vein needle punctures. Of the patients not included in the above categories, all but two received PEEP therapy of 10 centimeters H2O or greater. Thus, it appears the pulmonary barotrauma seldom occurs with airway pressure therapy in the absence of pre-existing lung abnormality or chest wall trauma. It is not unexpected that a significant incidence of barotrauma with airway pressure therapy exists in patients with COPD, in which blibs and air trapping are common, or with decreased lung compliance. PEEP therapy of 10 centimeters H2O or greater is associated with a significant incidence of barotrauma. However, this is usually attributable to the pulmonary disease process requiring therapy and must not be interpreted as a contraindication for the therapy. If the patient requires PEEP therapy, the risk of barotrauma is inherent. A 14% incidence of barotrauma has been reported in patients requiring PEEP therapy above 25 centimeters H2O. However, there is no data to support the assumption that barotrauma incidence increases in tandem with the PEEP level. It is our impression that PEEP levels between 10 and 30 centimeters H2O have the same incidence of barotrauma. Appropriate PEEP therapy should not be withheld due to fear of initiating barotrauma. Thank you so much. Peace. Good night to you as well. Highest heart love. Thank you so much for being here and reading with us. For the likes and subs, we're pushing towards 600 on this peaceful and quiet part of YouTube where we read books and learn from masters. We're at the middle of page 388. Pulmonary atelectasis and infection. Lobar and segmental atelectasis are common complications of airway pressure therapy. The diagnosis should be made within several hours to allow complete re-expansion by chest physical therapy techniques and or fiber optic bronchoscopy. The diagnosis is most commonly made by observing vital signs and or arterial blood gas exchanges and confirmed by chest x-ray. Pulmonary infection is a common complication of intubated patients in general. This has been discussed in Chapter 16. The most effective means of decreasing the incidence of these complications appears to be meticulous airway care and aggressive bronchial hygiene therapy. Yeah. Gastrointestinal malfunction. Gastrointestinal bleeding is a common in all critically ill patients. It has been estimated that without prophylactic therapy, as high as 40% of patients requiring IPPV for more than 3 days will have gastrointestinal bleeding. Very key to note. All those taking notes in the replays and then playlists. We are in 66th edition of this book reading. Amazing. 388 pages in. I told you we can do it. I knew it. I knew it. Thank you for breathing and reading with me. The diagnosis is most commonly made by observing vital signs and or arterial blood gas changes and confirmed by chest x-ray. Pulmonary infection is a common complication of intubated patients in general. This has been discussed in Chapter 16. The most effective means of decreasing the incidence of these complications appears to be meticulous airway care and aggressive bronchial hygiene therapy. I had to read that again. For 3 days, we'll have gastrointestinal bleeding. Half of these patients will have severe enough bleeding to require blood transfusion. Gastrointestinal bleeding is greatly increased in incidence and severity by the preexistence of gastrointestinal ulcer and long-term steroid therapy. It appears that the great majority of gastrointestinal bleeding, in conjunction with airway pressure support, is due to acute ulceration of gastric and bowel mucosa. Antacid regimens aimed at maintaining gastric fluid pH above 5.0, as well as early and frequent nasogastric feedings, have almost completely abolished major gastrointestinal bleeding. 4 units of blood or more caused by acute gastrointestinal ulceration in conjunction with airway pressure therapy. Cimetidine is a new drug that decreases the acidity of gastric secretion. Although used frequently at present, it affects on the incidence of gastrointestinal bleeding in patients receiving airway pressure therapy have yet to be established. The direct effects of airway pressure therapy on splanchnic blood flow are not presently known. However, some presumptive evidence exists that mesenteric blood flow may be decreased. Renal malfunction. Acute renal failure is a grave prognostic sign in all critically ill patients. Airway pressure therapy has been directly related to changes in renal function, CPPV, to a greater degree than IPPV. In general, positive airway pressure results in 1. Decreased urine output, 2. Sodium retention, and 3. Water retention. This may be partly attributable to increased levels of antidiuretic hormone, but more recent studies have revealed changes in the distribution of interarenal blood flow direct attributable to positive airway pressure. Although total renal blood flow may remain unchanged, renal function may be significantly impaired by airway pressure therapy in critically ill patients. CNS malfunction. Thank you so much for reading with us. So grateful. The effects of acute changes in PCO2, pH, and PO2 on cerebral blood flow are discussed in Chapter 34. With the exception of the effect on cerebral blood flow, there are no known direct effects of airway pressure therapy on CNS function. On the other hand, CNS malfunction is believed to have profound effects on pulmonary function and lung metabolic functions. Ding! Have to drop a pin there. The reason for malfunction. Thank you so much for reading books with us. When it's all complete, it will be in the playlist. You'll just tap on it and read the entire book for the whole next generation. That's what this part of YouTube is for. So thank you for being in peace and harmony with us here, live from the light. Psychologic trauma. Very key for taking notes on here. All right. Bottom of page 389 in the 25th chapter. Intensive care patients are exposed to significant emotional stress, especially patients on mechanical devices, e.g., ventilators, dialysis machines. The realization that one cannot breathe without the aid of a machine is frightening. Appropriate action of the intensive care staff is a necessity for the emotional well-being of the patient. Communicating with the patient, explaining procedures, and showing concern are the most obvious ways of meeting the patient's needs for emotional support. We did it. Look at her. Completion of chapter 25. We did it. Another completion of another chapter live from the light. We did it again. Did it again. So now we will move into section 7 of this book, cardiovascular monitoring and supportive therapy. Thank you so much for reading with us. Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. Look at this. Going into chapter 26. And we have the eagle tail feather here. Oh my goodness. Activation. So grateful and thankful for all I have now and all that is coming. Eyes on love. We're moving into the 26th chapter. Darn it. When we reconvene on the next book reading, live here from the light in LA. Thank you so much. I want you to have a wonderful day. We have a beautiful Your Healing session today. Can't wait. Go heal the people. That's what Thursdays are for here, right? I hope you enjoyed the reading and the love. Thank you so much. It's heart love. All right, let's have a glass of love water. Cheers to all our friends and family. Frankie Black, Solar Return that just came up. Lee Carmichael, other best friends, his birthday just came up. Happy Solar Return to the greats. Generation X, superheroes in real life. We're doing it. Love. Love to all our friends and family. Love you. Thank you so much. All my mods, all the YouTube world of book readers. Love to you. I love you. Mm. Mm. Love water. I love you. I love you. I love you. Shaking it up on YouTube. Reading masterful books. Right? I want you to have a wonderful day. Remember, always stay on your square. You know your purpose. You know what you're doing. Shaking it up. Hey, 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 Peace, peace. Yes. Thank you so much. Highest heart love. I will see you soon. Live from the light here in LA. Want you to have a wonderful day. I love you. I love you. You know it, because I love myself. I love you, Bubbles. I love you so much. Highest heart love, Mom and Dad. I'll see you soon. Peace, peace.